Postoperative pain management has been dominated by one class of drugs for decades, that is opioids. They work, they are powerful, but they come at a cost. What if I told you that large number of new opioid addictions actually begin after surgery and that modern surgical practice is now actively trying to move away from opioids? Welcome back to our channel. In this session, we will explore why surgeons are shifting away from traditional postoperative opioids and how newer concepts like ERAS protocols and multimodal analgesia are changing the patient outcomes. This is a high yield topic for NEET PG, MBBS, and clinical practice because it connects pharmacology with the real world surgery. By the end of this lecture, you won't just memorize the drugs, you will also understand the future of pain management. So, let's begin. The opioid problem. Now, the key question is why was this shift even necessary? Opioids are effective painkillers, but they come with a significant cost. Now, here is a striking fact. Nearly 70% of the new opioid addictions begin after a surgical prescription, and about 5 to 8% of the patients go on to develop persistent opioid use even after short term therapy. So, now look at these side effects. Nausea and vomiting. Patients can tolerate the oral intake. They cannot tolerate this. Constipation leading to ileus, gut function slows down. Sedation delays early mobilization. Respiratory depression, potentially life threatening, and most importantly, risk of addiction. So, while opioids control the pain, they actually delay the recovery and increase the complications. And that's what pushed modern surgeons to rethink, can we manage pain effectively with fewer or no opioids? And that's exactly where the shift is important in the post operative care. And so it begins here. Opioid receptors and addiction. Now let's understand the pharmacology behind the opioids because this explains everything. There are three main opioid receptors: mu, kappa, and delta. But the most important one is the mu receptor. Why? Because it is responsible for analgesia, euphoria, respiratory depression, and most importantly, dependence and the addiction. Now, here's how the addiction actually happens. Opioids bind to the mu receptors in the brain. This activates the reward pathway, especially the ventral tegmental area, leading to a surge of dopamine release in the nucleus accumbens that creates a feeling of pleasure and relief. Now, the brain wants to experience that again and again. Over time, receptors get downregulated, the same dose gives less effect, and this is the tolerance. And when the drug is stopped, withdrawal symptoms may appear. This cycle leads to craving, dependence, and addiction. So, here is your key takeaway. The same receptor that gives the pain relief is also responsible for the addiction. And that's exactly why relying on opioids alone becomes a major problem in the postoperative care. ERAS protocol. Now, this is where the modern surgery takes a big leap. ERAS, Enhanced Recovery After Surgery. This is not just a protocol, it is a complete shift in how we manage the surgical patients. ERAS work across three phases. Preoperative phase focus on the patient optimization, no prolonged fasting, proper counseling, and even carbohydrate loading just 2 hours before the surgery to reduce the stress response. Next is the intraoperative phase. Use minimally invasive techniques, short acting techniques, and short acting anesthetics, and maintain the fluid balance and the body temperature. Next is the postoperative phase. This is the game changer. Early oral feeding from day 0, early mobilization from day 1, and most importantly, multimodal analgesia instead of opioids. And the results, 30 to 50% reduction in the hospital stay, up to 80% reduction in the opioid use, faster recovery, fewer complications. So, ERAS is not just about the pain control, it is about faster, safer, and smart recovery. And this is exactly why opioids are being replaced. So, if we reduce the opioids, how do we control pain effectively? The answer is multimodal analgesia. The idea is simple but powerful. Don't depend on one drug. Use multiple drugs with different techniques and different mechanisms. Each drug targets pain at different level of the pathway. For example, NSAIDs block the prostaglandins, reducing the inflammation. Paracetamol works centrally, raising the pain threshold. Gabapentinoids reduce the nerve sensitization. Local anesthetics block the nerve conduction directly. Alpha 2 agonists provide sedation plus analgesia, and low dose ketamine prevents central sensitization. And now, here is the advantage. Instead of giving one drug at a high dose, you can give multiple drugs at lower doses. So, you get better pain control, fewer side effects, and minimal reliance on opioids. That's why this is called an opioid sparing strategy. And this concept is at the heart of the modern surgical care. Now, this is where things get even more powerful. Regional anesthesia. Instead of affecting the whole body, you block the pain exactly where it starts. Look at these key techniques. Epidural analgesia. This is the gold standard for major abdominal and thoracic surgeries. It provides excellent pain relief and allows the early mobilization. Tap block. Transversus abdominis plain block, very commonly used in the laparoscopic surgeries, C sections, and hernia repairs. It's ultrasound guided, simple, and can significantly reduce or even eliminate the opioid need. Spinal anesthesia, used in the lower limb and the pelvic surgeries, gives long lasting analgesia with minimal systemic effects. Next is the wound infiltration, the simplest method, injecting local anesthesia directly at the incision site. Gives 6 to 12 hours of effective pain relief. So, the key idea is block the pain at its source instead of suppressing it centrally with opioids. This leads to better pain control, faster recovery, and minimal systemic side effects. So, this is becoming the backbone of the opioid free surgery. Now, let's translate all of this into real prescriptions. What do we actually use in practice? Ketorolac, a powerful NSAID. Give IV, excellent for acute postoperative pain, but remember, limit to 5 days and avoid renal impairment. IV paracetamol, often underestimated but very effective. Standard dose 1 gram every 6 hours with a max of 4 grams per day. Pregabalin, given preoperatively 75 to 150 mg, as it can reduce the postoperative opioid requirement by up to 40%. Dexmedetomidine, an alpha 2 agonist, provides sedation plus analgesia with minimal respiratory depression. This is a huge advantage. Ketamine, at sub-anesthetic doses, it acts as a NMDA antagonist, preventing the central sensitization and sparing opioid use. Tramadol, a weaker opioid, sometimes used but not truly opioid free. Also, watch for the serotonin syndrome in such patients. And finally, the bupivacaine, used in epidurals, nerve blocks, and wound infiltration, a key player in regional analgesia. So, the takeaway, pain control today is not about one drug, it's about choosing the right combination for the right patient. Let's understand why opioids actually slow down recovery system by system. Central nervous system. They cause sedation and drowsiness, along with nausea and vomiting due to CTZ stimulation. And the classic sign, pinpoint pupils. Next is the respiratory system. This is the most dangerous effect, respiratory depression. Opioids reduce the body's response to carbon dioxide, and an overdose can lead to apnea, especially risky in elderly or COPD patients. Next is the gastrointestinal system. They reduce the gut mobility, leading to the constipation and post-op illness. That means delayed feeding discomfort, and longer hospital stay. Urinary system. They cause urinary retention by relaxing the detrusor muscle, increasing the need for catheterization and risk of the UTIs. So while opioids relieve pain, they negatively impact multiple organ systems. And this is exactly why modern protocols aim to minimize or eliminate the opioid use wherever possible. One quick exam point. In opioid overdose, the antidote is naloxone, which is given IV. Understanding these side effects is to understand the shift away from the opioids. Now, let's bring everything into real clinical practice. First, laparoscopic cholecystectomy. Preoperative pregabalin plus paracetamol. Intraoperative tap block. Postoperative paracetamol and ketorolac and opioids only if the pain score is very high. Result: most patients go home opioid free the same day. Next, major abdominal or colorectal surgery. Here, we use an epidural catheter for continuous analgesia combined with scheduled non opioid drugs. Patients are able to walk on day 1, eat early, and are discharged faster. And total knee replacement. Use nerve blocks like femoral or IPAC plus spinal anesthesia and non opioid medications. Patients can even start walking the same day. And here's the key principle: opioids are not first the key line anymore, they are used only as rescue therapy, typically when the pain score or VAS is above 7. And that's how we achieve faster and safer recovery. Alright, this slide is pure exam gold. Let's lock in the key points. ERAS stands for the Enhanced Recovery After Surgery. Goal is a reduced hospital stay, reduced opioid use, and faster recovery. Mu receptor, the most important opioid receptor, responsible for both analgesia and addiction. Antagonist, what was that? Naloxone IV or naltrexone oral? Tap block. Remember the anatomy between the internal oblique and transversus abdominis muscles. Multimodal analgesia, combination of NSAIDs, paracetamol, gabapentinoids, and local anesthesia. Ketorolac, strongest NSAID for acute pain, but limit use to 5 days and avoid in renal issues. Ketamine at low dose and NMDA antagonist, very important for opioid-sparing effect. Post-operative ileus, a classic opioid effect, ERAS reverses it with early feeding and mobilization. And finally, dexmedetomidine provides sedation without respiratory depression, a very important advantage. If you remember these points, you can easily handle both the MCQs and the clinical scenarios. Now let's look everything with a simple mnemonic. Opioid HARMS harms, opioid harms. Because honestly, opioids do exactly that. They harm the recovery. Let's break it down. O for obstruction of GI, constipation and ileus, gut function slows down. P is pruritus, histamine release causing itching. I is ileus delay, postoperative feeding gets delayed. O is oversedation, which leads to respiratory depression risk. I is inhibition of mobilization. Patient can't get up early and recovery slows down. D is dependence. Addiction risk is always there. Harms. H, hypertension. A, addiction pathway. R is retention of the urine. And M is meiosis and nausea or vomiting. These are the classical opioid effects, and S is the sensitization issues. So if you remember the mnemonic opioid harms, you will never forget where modern medicine is moving away from them. And that's the whole point of the shift. Let's wrap up with a 60-second rapid revision, perfect for last day prep. ERAS, preoperative, intraoperative, postoperative optimization. Goal is to reduce the hospital stay and minimize the opioids. Next is the multimodal analgesia, combine NSAIDs, paracetamol, gabapentinoids, and local blocks. Neuroreceptor gives analgesic but also addiction. Antidote is naloxone IV. Tap block, between the internal oblique and transversus abdominis, USG guided. Dexmedetomidine, sedation without respiratory depression, very important. Ketamine at low dose, NMDA antagonist, opioid sparing and prevent central sensitization. Opioids cause ileus. ERAS reverses this with early feeding and mobilization. Pregabalin preoperative can reduce the opiate requirement by around 40%. So, if you remember these 8 points, you are fully prepared for both exams and the clinical practice. Now, let's close this session. So, to conclude, postoperative pain management is no longer about giving opioids. It's about smarter, safer, and patient centered care. With concepts like ERAS protocol, multimodal analgesia, and regional analgesia, we can achieve effective pain control while minimizing complications and addiction risk. This shift is not just important for the exams, it's the future of the clinical practice. If you understand this approach, you are not just preparing for NEET PG, you are preparing to be a better clinician. Thank you for watching. If you found this video helpful, don't forget to like, share, and subscribe our channel. See you in the next session.